Good evening, everyone. Thank you for confirming, Bhumi Sinha. I hope I'm audible and visible to all of you, right? So, welcome to this Farre session in dermatology. Myself, I'm Dr. Jazeer, your dermatology faculty at PW MedEd. And today, we will be discussing about eczema and some of the common skin infections in this lecture. Yeah, like last year we had covered many of the important topics like psoriasis, vitiligo, isn't it? So all those things were covered. So basic idea here is we would like to cover almost all of those important topics. So today we will be doing mostly atopic dermatitis, contact dermatitis, bacterial, viral, fungal infections. Like what is the type of long answer question? What is the type of short answer questions that can be asked? And yes, very good evening, Supata, Osama, all of you. And whenever you feel something is there which is not very clear, whenever you are in doubt, please feel free to discuss. Okay? So with your permission, I will just get started. So some few things regarding this lecture, because this is the first time that we are doing a foray this year, right, for dermatology. So the idea is these topics, जैसे atopic dermatitis, contact dermatitis and all, मैंने divide किया है topic wise, and each topic comes with a question, right? Like how, what, in whichever type you may expect for your final year exams, and question driven approach hoga, but we will try to cover almost all the important points that is in with regards to each and every topic. So that is a basic idea. Now what happens here is when you are going to give a subjective kind of a exam जहाँ पे आपको short answer या long answer लिखना पड़ता है, then whatever is a topic that is asked when it comes to dermatology, always try to define. अगर psoriasis के बारे में question पूछा है, then define what is psoriasis. If a question is on vitiligo, define what is vitiligo. Is it a autoimmune disease? क्या होता है इस disease में, isn't it? So a simple definition which will definitely carry some weightage. Then you have to explain what is a core feature of this disease. And like how will the patient present to you with this disease? Is there any criteria for the diagnosis? Is there any classification? And finally, iska management kya ho sakta hai, right? So that is how we can actually divide all these things one by one in a systematic way when we describe this on a subjective way. So to begin the lecture, let's start with the first one, that is atopic dermatitis. Now all of you just see what is the question that is asked. Define atopic dermatitis, describe its clinical features, diagnostic criteria and management. अभी इसमें question itself is very structured, right? पहले define करो, फिर उसके बाद इसका clinical features के बारे में बताओ और diagnostic criteria के बारे में बताओ, and finally management. Now let's see how we have to structure this answer so that you also do a similar pattern or a similar way when it comes to a long answer question for dermatology. Now see, we will go according to whatever has been asked. पहले define करेंगे, clinical features बताएंगे, diagnostic criteria के बारे में बताएंगे, and then finally we will talk about management. Very good evening, Raju Fit. Okay, so now let's start with the first one. Do anybody of you know how do we define this topic called atopic dermatitis? कैसे define करना चाहिए atopic dermatitis को? Any idea? First of all, atopic dermatitis is a chronic condition, right? Chronic condition. It is a relapsing condition, inflammatory condition of the skin. Okay, chronic relapsing inflammatory condition of the skin which is characterized by dry skin, right? Whenever the skin becomes dry, फिर क्या होता है? There can be some pruritus. Pruritus मतलब itching, right? Dry skin, pruritus, and eczematous lesions. And eczematous lesions in the skin, right? So all these things are very important when you define atopic dermatitis. Along with that, we have to add one more important point. Along with a personal or a family history of atopy, along with a personal or a family history of atopy. अब देखो कि what is the definition? Definition itself we are able to give such a big definition, right? क्योंकि atopic dermatitis क्या है? It's a chronic disease. It's a relapsing, मतलब it comes and goes, comes and goes. It's a relapsing condition. It's an inflammatory condition of the skin. And in this condition, what can you see? You can see dry skin hoga, isn't it? Whenever the skin is dry, there can be itching or pruritus, right? And along with that, we can see some rash. कौन से type के rashes होगा? Eczematous rash देख सकते हैं. And in all of these patients, what will you see? Personal history या फिर family history होगा atopy का, right? Of atopy. So that is about the basic definition of atopic dermatitis. Now, if you want to give what is this atopy, you can definitely mention कि atopy मतलब ये allergic rhinitis का history होगा, allergic rhinitis और bronchial asthma, isn't it? Allergic rhinitis and bronchial asthma का history हो सकता है, personal history या फिर family history. That is about atopic dermatitis. Now, what are the clinical features? Now, in the clinical features, it can be different types of symptoms, right? So, the symptoms or the clinical features, the first clinical feature should be dry skin. These patients, they always have a dry skin. Second thing is that whenever the skin is dry, there will be pruritus. This pruritus is the hallmark feature. ठीक है? This pruritus is hallmark feature. हाँ तो atopy मतलब allergy. Right? Atopy, there are two diseases. जैसे ऐसे याद रखो कि upper respiratory tract में हो गया allergic rhinitis, lower respiratory tract में हो गया bronchial asthma. All these are related to allergy. ठीक है? So now let's see. Dry skin हो गया clinical features. Pruritus हो गया दूसरा, isn't it? This is the most common, and this is a disease where there is a itch, scratch, itch cycle. So this is a disease जहाँ पे the patient will be itching, फिर scratch होगा, isn't it? Itching वाला sensation होगा, the patient will scratch the skin, फिर से itching होगा. That is why this is a disease where we call there is a itch, scratch, itch cycle. Itch, scratch, itch cycle. And the most important feature in this clinical feature is age-based distribution hoga. Age-based distribution of the rash. Now, what is this age-based distribution of the rash? Age-based distribution matlab in infants, यहाँ पे you will get the lesion over the face and extensor surfaces. Okay, in infants you can see the lesions over the face and extensor. ये हो गया extensor, right? So you can remember. Yes, definitely, Subhad. So what will happen is here in these cases, these are the kids, right? The infants will be crawling. So when they crawl, what happens? There would be some rashes over the extensor surface. इसीलिए in clinical features, infants में face and extensor surfaces are going to be involved. Whereas in the cases of children and adults, यहाँ पे you can see the lesions over the flexures. You can see the lesions over flexures, okay, over the folds. That is what is the basic difference between these lesions, which can be seen based on the age, okay? So now, how do you diagnose? There was the question. First they asked you definition, clinical features. Now we are going to the diagnostic criteria. अभी diagnostic criteria के लिए there is a major diagnostic criteria. See, these are distribution patterns. Supata, जैसे if the question says a 5-month-old infant with atopic dermatitis, the distribution will be over the face and extensors. That is the most common distribution pattern. Whereas a 2-year-old child or a 5-year-old child with atopic dermatitis, आपको ये patient का antecubital fossa में देखना पड़ेगा, right? Because that is the flexural aspect. That is a common distribution of the rash in this disease. Now, coming to diagnostic criteria, first you have to name the criteria. It is called as Hanifin and Rajka criteria. Okay? The name of the criteria is called as Hanifin and Rajka criteria. जहाँ पे there are 4 major criteria and there are 23 minor criteria, isn't it? There are 23 minor criteria. Abhi, who can remember 23 minor criteria, right? But यहाँ पे जो 4 major criteria है ना, वो 4 major criteria we can definitely mention, क्योंकि सिर्फ 4 ही याद रखना है, right? So what are the 4 major criteria in atopic dermatitis? एक हो गया pruritus, isn't it? So one is pruritus, matlab there will be lot of itching. There will be the second one is a typical morphology, isn't it? Typical morphology and distribution of the rash. Typical morphology and distribution of the rash, which I will explain you again. There is a chronic and relapsing rash, है ना? Chronic and relapsing rash या फिर course. And the fourth one is going to be personal or family history of atopy. Personal or family history of atopy. ये कैसे वर्ड्स है? So don't worry. I mean ये वर्ड्स है ना, अभी इसको आप थोड़ा और भी सिंप्लीफाई कर सकते हैं. जैसे प्लीज रिमेंबर 4 मेजर क्राइटेरिया है ना? एंड फ्यू ऑफ यू आर क्राइंग इन द चैट बॉक्स कि अभी इसको कैसे याद रखूं. सिंपल है. इफ यू वांट टू रिमेंबर इट, you just ask the patient, ask 3 questions, okay, and check the skin rash. उतना ही है. But this is not for your exam. Don't write ask 3 questions and check for the skin rash, okay? And now what will be your 3 questions? Do you have a itchy skin, right? The patient will say yes. Itchy skin matlab pruritus. Itchy skin matlab pruritus. हो गया ना 1 question. Second thing, is this lesions coming and going, the symptoms कैसे हैं? बहुत chronic है क्या, right? So for that thing also, this is a second question. Third question, do you have repeated sneezing जैसे allergic rhinitis, या फिर bronchial asthma, या फिर wheezing का issue है क्या? That is the third question. See, 3 questions are asked. 1, 2, 3. 3 हो गया अपना final major criteria में, right? And the next one is check for the rash. What is a rash? अगर the age of the child is less than 1 or less than 2 years, face में और extensor surfaces में you'll be able to see the skin lesions. वो हो गया morphology and distribution of the rash. If the age is more than 2 years, you will be seeing the rash in the flexures. वो हो गया typical morphology and distribution of the rash. ठीक है? So that is how we can conceptually build. और language, आप कई language use करो, है ना? You can use your own language. And 23 minor criteria है जो हम we cannot write 23 minor criteria. इसमें क्या कर सकते हैं? you can just give a hyphen and list some of them. जैसे ड्राई स्किन को क्या बोलते हैं? सीरोसिस, है ना? ये जो पेशेंट्स में जिनको एलर्जी होगा, इनका सेरम IgE लेवल्स विल बी इंक्रीज्ड, एलिवेटेड सेरम IgE होगा, राइट? देन what else can be seen? There can be a lot of other features. Loss of lateral eyebrows होगा, क्योंकि they'll be rubbing the eyes. Loss of lateral eyebrows, etc. So all these features can be seen. So just इतना ही लिखो कि minor criteria there are 23: dry skin, elevated IgE, loss of lateral eyebrows. There are many other, recurrent conjunctivitis. All those things can be there. So that is why we will use this word, etc. Right? Yes, itching and pruritus are the same. Clear? So that is about the various diagnostic criteria which comes when in terms of atopic dermatitis. And in all the eczema, ये चीज याद रखना कि when you write the differential diagnosis, हर eczema you can keep it as a differential diagnosis. जैसे हो गया seborrheic dermatitis can be one of the differential diagnosis. Contact dermatitis can be one of the differential diagnosis, isn't it? All those things can be kept as a differential diagnosis. And then coming towards the next one, that is the management. Now, when it comes to management of atopic dermatitis, now just, okay, sure. Now, when it comes to atopic dermatitis, just imagine what should be the management, right? What is a patient having? Is a patient having a well moisturized skin? Yeah, dry skin. The patients are having a dry skin, right? So when the patient is having a dry skin, your first line should be moisturizers is the first line of therapy. Okay, so you got this magic word. First line of therapy should be moisturizers. And then you can go for steroids if eczematous rashes are present. So if eczematous rash is present, then you can start the patient on steroids or calcineurin inhibitors. So these are the two treatment: moisturize. That is going to be the first line, and then Cetaphil moisturize. But you cannot give Cetaphil moisturizer in your exam, right? So you can just write down moisturizers. That is more than enough. And then you can write down steroids or calcineurin inhibitors. Abhi, if there is a complaint of itching, the patient is always having dry skin and itching. For itching, what are you going to prescribe? Please write down in the chat box. Itching के लिए आप क्या prescribe करोगे? Yeah, you can go for antihistamines for itching, right? So that is how you can treat all these cases of atopic dermatitis. And in the last, please also mention that there should be some general measures. Okay, what do I mean by general measures? To avoid hard soaps, isn't it? Chemicals, loose clothings, and all those things can be done, isn't it? So what you can do is general measures. जैसे dry skin कैसे हो सकता है? When you wear tight clothing, so move to loose clothing. Avoid those very harsh soaps and all. Use some gentle cleansers. All those things can be done. So these are the see calcineurin inhibitors का example है like tacrolimus, pimecrolimus, etc. If you want, you can note it down as well, like tacrolimus or pimecrolimus. See, why do we use a calcineurin inhibitor is because when you apply a steroid cream, there are a lot of side effects which can be seen. whereas the side effects are much less and they give equal effect like what a steroid can actually provide. That is why we use calcineurin inhibitors. Clear? See, any specific soap, matlab, see Dove or anything that is not harsh. Okay, that is what we can see, which is usually prescribed. Done. That is these are the ones which is usually used in the OPD in cases of a atopic dermatitis. Yeah. Yeah. So that is all about this question. So in case you get a long answer question like this, please structure it with a definition, with a clinical feature, with a diagnostic criteria, and finally management. Definition सबसे important है. So in definition, please make sure that you give a very elaborate and a simple definition like what we have done, and then based on the clinical features, जो features सबसे important है उसको आगे रखो. Like in atopic dermatitis, itching is the most important symptom, dry skin is a second very important symptom, right? And accordingly some morphological changes can also be mentioned. Then coming to diagnostic criteria, in this disease there is a diagnostic criteria called Hanifin and Rajka, where there are major and minor criteria, right? So we have mentioned about major and minor criteria, and then finally management. Okay. Finally there is a management as well. Now in this thing, what you need to make a diagnosis is what we have not mentioned here. For diagnosis आप mention कर सकते हो. For diagnosis there should be at least 3 major criteria plus 3 minor criteria to make a clinical diagnosis of atopic dermatitis. So out of 4 you need 3. Out of 23 you need just 3. Okay, so that is what you need to remember for the diagnosis of atopic dermatitis. Is that clear? So that is about the first question. So now let's see another question. Differentiate between allergic contact dermatitis and irritant contact dermatitis. Now, how will you approach this question? As you know, let's imagine कि ये एक short answer question है. You need to differentiate. Will you directly jump into differentiating between allergic and irritant contact dermatitis? Don't do that. Now here, first once again, please write down a definition. What is a allergic contact dermatitis or a irritant contact dermatitis? So what do you mean by a contact dermatitis? Just apply common sense. Contact dermatitis matlab when there is a contact of an external object to our skin. If you develop a skin rash at the site of contact, इसको बोलते हैं contact dermatitis, right? So what is a contact dermatitis? By definition, you can just write down contact dermatitis is an inflammatory reaction isn't it? It is an inflammatory reaction of the skin caused by what? Caused by what? Is it by a bacteria? Is it by a virus? Nahi hai na? It is a dermatitis. It is an allergy. It is caused by the exposure to external agents. So see the sentence. Contact dermatitis means there is an inflammatory reaction in our skin which is caused by an exposure by an external object or an external agent to our skin, which is classified as, just give 2 apostrophe, 1 allergic contact dermatitis and 2 irritant contact dermatitis. Now it makes sense. Now we have connected both. Contact dermatitis means it is a because of an exposure to external agents, and which is classified into 2 types, allergic contact dermatitis and irritant contact dermatitis. Now what do we do is, now we can directly jump to the question. क्योंकि question में क्या पूछा था? Differentiate. Now let us write down the differences between allergic contact dermatitis and irritant contact dermatitis. So let me just write down ICD here, irritant contact dermatitis, and ACD here. So in a tabular format. So in this table, our first finding here will be, why does ICD happen? So ICD, it happens due to innate immunity, whereas ACD happens because of a type 4 hypersensitivity. It happens because of a type 4 hypersensitivity. Very good, Tanisha. You're saying about Parthenium. I'll come to Parthenium in some time. So that is the right answer as well. So first thing we have discussed about the mechanism. एक में क्या हो रहा है? There is a innate immunity. The second one is because of type 4 hypersensitivity. The second one is regarding the clinical features. Clinical features. What happens in irritant contact dermatitis is there will be complaints of dry skin and irritation at the site of contact. At the site of contact. ICD matlab irritant contact dermatitis. Okay? Because the question itself was that, right? Differentiate between irritant contact dermatitis and allergic contact dermatitis. ये हो गया ICD. ये सुपता. Okay. So now coming to the next one is what happens in allergic contact dermatitis. I'll just write down first, फिर मैं explain करता हूँ. So what happens in allergic contact dermatitis is the patient will complain of eczematous rash at the site of contact on repeated exposure. Now let's see what is happening in both, and just try to understand so that you can write down the answer in your own sentence. Now if I give you an example, it becomes much more easy. Okay, so the example here is, let us write down the example here. Sanitizers, detergents and dishwash. ये हो गया इधर examples. And allergic contact dermatitis में the example is like what Tanisha was answering. Parthenium, Hysterophorus, bindi, henna, footwear, cement, etc. Okay, so that is what the examples of allergic contact dermatitis is. Now just focus here, just listen to me carefully. I'll just explain you, there is no confusion here. Okay, what happens in an irritant contact dermatitis? Just imagine what will happen if you are going to apply a hand sanitizer. Hand sanitizers, once you use, what happens? Your skin becomes dry. You feel there is some irritation, right? So that dryness, that irritation that you feel over your skin, when your skin comes in contact with chemicals like sanitizers, detergents, or dishwash, this is called as irritant contact dermatitis. Clear? Now see what is happening in allergic contact dermatitis. Now here, let me tell you about a bindi dermatitis. A patient was using a bindi. On the first day, there is no rash. Second day, third day, there is no rash. What happens is, once she is using the bindi on the fifth day, there is a eczematous rash which appears. Why is there a eczematous rash? At the site of contact, like at the site of contact on repeated exposure, क्योंकि यहाँ पे sensitization की ज़रूरत है. Only when there is a sensitization, that is when a rash appears in allergic contact dermatitis. That is why a patient may come to you, the patient is having a wristwatch allergy, but the patient had no symptom on day 1, day 2, day 3, day 4, day 5. Symptoms appeared on day 7. Why? Because on repeated sensitization, that is when the patient will develop allergic contact dermatitis. Now tell me why there is a delay in symptoms. So there is a delay in the onset of symptoms because of, what is the reason? Because of type 4 hypersensitivity. Type 4 matlab delayed hypersensitivity. That is why there is a delay in the symptoms. Is that clear? So I'm a NEET student. Hi Ritika. So that is about this allergic contact dermatitis, and hair dye is also an example. Exactly. Very good. So hair dye can be an example. Yeah, another example can be cosmetics, isn't it? So how do you remember for your exam? Everything other than sanitizer, detergent, dishwash. Your answer can be allergic contact dermatitis like parthenium, bindi, henna, footwear, cement workers, hair dye, cosmetics, nickel dermatitis. Everything else comes under allergic contact dermatitis. Is that clear? So that is about allergic contact dermatitis. So we have differentiated both. Okay? And in both the cases, the treatment, ornaments also is going to be type 4. See, ornaments mein what will happen is, mostly it happens with artificial jewelry. Okay, with artificial jewelry. So with the repeated exposure, the patient will develop allergic contact dermatitis at the site. And the treatment of both is going to be steroids, okay, which is the drug of choice. Steroids are going to be the drug of choice. Now let's move to the next question. It is about seborrheic dermatitis. So what is the question? Write a short note on seborrheic dermatitis. So when you get something like this, then you may be confused कि क्या क्या लिखना पड़ेगा. So if there is a question on a short note on a certain subject or a certain topic, then it is better follow the same protocol. Just define it in a simple word. Okay, write down what is the clinical feature. If there is any, how do you make out a diagnosis? And how do you reach out to a treatment? Just 4 sentences or whatever it is. So let us write down the core content when it comes to a seborrheic dermatitis, right? So seborrheic dermatitis is what we usually call as a dandruff, right? So just write down the definition. Seborrheic dermatitis is again, it is a chronic inflammatory dermatitis, okay, affecting the seborrheic sites in the body. So that is the definition of a seborrheic dermatitis. What is happening? It is a chronic condition which is affecting the seborrheic sites in the body. And what is a common clinical feature? Which is, so you can just give a comma and you can write down characterized by erythema and yellow greasy scaling. Characterized by erythema and yellow greasy scaling of the skin. And then you can write down what can be the reason why a patient will develop seborrheic dermatitis. So here the etiology, I just saw one of the etiology in the chat box, because Sutapa Samantha has given that it is because of a fungi. Very good. So in the etiology, you can write down there is a fungus. You can even write down the name of the fungus, that is Malassezia furfur. It is because of Malassezia furfur. Not only because of Malassezia furfur, because of increased sebaceous activity, sebaceous discharge, या फिर sebaceous activity, and some hypersensitivity. So these are the reasons behind a seborrheic dermatitis. So here Atul was asking what is a seborrheic sites. अब ये देखो seborrheic sites मतलब upper part of the trunk. See, this is the upper part of the trunk if you can see my video, right? So in upper part of the trunk, what all things will come? The scalp, then it, the forehead, the cheek, the chin, the upper part of your shoulder, anterior part of the sternum, and behind the ears. All these things, for easy thing, upper part of the trunk is the seborrheic sites. That is why the most common site where you can see a seborrheic dermatitis, what is it? Dandruff. Where is it most common? कहाँ पे दिखता है dandruff? Yes, you can see the dandruff over the scalp, right? That is the most common site of dandruff or seborrheic dermatitis. Now, coming to all these things, you can also write that seborrheic dermatitis when it comes to the where do you see is seen in infants. In infants, it is called as cradle cap, isn't it? As well as in HIV patients, patients with neurological diseases, and in normal individuals, and can be seen in normal individuals also because of the hypersensitivity reaction, isn't it? Because of the hypersensitivity reaction. So in all these category, you can see. Now, how do you treat a patient with seborrheic dermatitis? Because there are two types of thing that is happening in seborrheic dermatitis. What is happening? One is there is a fungus called Malassezia furfur. The second thing is there is increased sebaceous activity, matlab oily skin and all. And then there is a hypersensitivity as well. So that is why if there is Malassezia furfur, which is the fungus, then we can treat the patient with antifungal shampoo. So what are the antifungal shampoos that is available? Like ketoconazole or selenium sulfide can be used. If the patient is having a lot of hypersensitivity, then you can also note it down. Plus minus steroids can also be used for the management. Steroids can also be used. So that is about the management of seborrheic dermatitis. So in seborrheic dermatitis, short note, we just mentioned that's a definition. It is a chronic inflammatory condition which can be seen in seborrheic sites. What is the cause? Malassezia furfur, sebaceous activity, hypersensitivity and all. And finally, treatment. Treatment mein we are going to use antifungal shampoo plus minus steroids. Yeah, clobetasol and all is becoming a steroid. Very good, Tanisha. Okay. Steroids mein it is not very particular which steroids. Like if you want, you can give an example like betamethasone, mometasone, etc. can be used. Okay, so these are some of the examples of the steroids which can be used. Clobetasol, you have to be a bit careful, Tanisha, because it is a high potent steroid. So if it is a high potent steroid, there is a chances of side effects also. So be always careful when you use a high potent steroid. Yeah. So now let's go to the next question. The next question says, describe the types of impetigo. Now, when the question is types of impetigo, again, please don't directly jump. There are two types or three types. First, tell what is an impetigo. है ना? So we have to give a short definition for an impetigo. So first write down that impetigo. Any idea what is an impetigo? Is it a eczema? Is it a bacterial infection, fungal infection, viral infection? Any idea? Samantha, seborrheic matlab seborrheic sites. Okay. Seborrheic sites like the upper part of the trunk, जहाँ पे lot of sebaceous activity is happening. The like when there is an increased sebum production, right? That is why we are having a oily skin and all. I hope it is clear. Now, please tell me Impetigo. Quickly in the chat box, please. You must have read about Impetigo. What is Impetigo? Bacterial, fungal, viral, or dermatitis, eczema. Very good. Samantha is answering it is bacterial. I completely agree with you. Like Impetigo is a contagious superficial bacterial infection of the skin. See this definition? Very simple, hai na? Impetigo is a contagious, which means it can spread from one person to the other, and it is superficial. It is not deep, and it is a bacterial infection of the skin, which is most commonly seen in children. Which is most commonly seen in children. That can be the definition of an impetigo. And now let us try to describe the types of impetigo. What are the types of impetigo? So first write down there are two types. The first type is called as non-bullous impetigo, and the second type is called as bullous impetigo. Okay, there are two types, non-bullous and bullous type of impetigo. Clear? And then let us write down what are the differences. The first difference is based on the causative organism. Non-bullous. What is the meaning of a bulla? Bulla is a large lesion which contains a clear fluid. Just as we can see in the burns and all, right? So here, in case of a non-bullous impetigo, you can see that this is usually caused by streptococcus more commonly than staphylococcus. That is one difference. Whereas bullous impetigo is caused by staphylococcus aureus commonly. Okay? The second difference is based on the crust. In non-bullous impetigo, you can see golden yellow honey colored crust. You can see golden yellow honey colored crust. Whereas bullous impetigo, you can see a varnish crust. Varnish means like we use this varnish over the windows, over the doors and all, right? So that has a brownish color. That is why it is called as a varnish crust. Okay? And the next feature is that in the case of non-bullous impetigo, since it is caused by streptococcus more commonly, then here the complication is PSGN. So any idea what you mean by a PSGN? Post streptococcal glomerulonephritis, right? So this is called as post streptococcal glomerulonephritis. That is a complication that is associated. Whereas what is a complication that is associated when there is a staphylococcal infection? Staphylococcal infection ka complication is 4S. So what is the meaning of 4S? Hi Ruchi Bansal, good evening. So the 4S means staphylococcal scalded skin syndrome. So it means staphylococcal scalded skin syndrome. So that is going to be the complication that is associated with bullous type of a impetigo, okay, with a bullous kind of a impetigo. So these are the basic differences, which we have done in a table. So whenever you get something which has to be compared, आप ऐसा compare करो like in a tabular format. One is caused by streptococcus, one is caused by staphylococcus. In one you can see yellow color crust, the other one you can see a varnish colored crust. Please tell what is the difference between purpura, petechiae, ecchymosis. Very simple. Okay, since you asked about it, I'll just explain that and proceed further. So first thing is petechiae. Okay, the second one is purpura, and the third one is ecchymosis, right? So the basic difference is, just imagine there is a blood vessel, and within the blood vessel, what is present? There is blood inside the blood vessel. What happens when the blood comes out of the vessel? So when the blood comes out of the vessel, there can be some small bleeding spots. Sometimes these bleeding spots can be bigger in size. Sometimes they can be very big in size. So when the blood will come out of the vessel, when the size is less than 0.3 centimeter, it is called as petechiae. When the size is between 0.3 centimeter to 1 centimeter, this is called as purpura. When the size is more than 1 centimeter, it is called as ecchymosis. Okay, just say in dengue fever. So example here is dengue fever, where you can see pinpointed bleeding spots. Okay, petechiae. Purpura, the example can be Henoch, Scholin, purpura, isn't it? Or let's say idiopathic thrombocytopenic purpura, ITP. So in those things, there are large bleeding spots, that is called purpura. And just imagine that I'm going to punch you over your eyes today. And next day morning, you get up with a large bruising. It is called as ecchymosis. It is called as ecchymosis. More than 1 centimeter. Is that clear? So now moving further, I just discussed about it because one of you asked a doubt. So now moving further, let us see another question. Differentiate between cellulitis and erysipelas. Now you see, there is one more question where we are being asked about cellulitis and erysipelas. Now let us see how do we differentiate. So before we differentiate, first let us write down a definition that cellulitis and erysipelas are bacterial infections of the skin Okay, simple thing. Treatment of impetigo is the thing that many of you are asking. So treatment of impetigo, here we need not break our head too much because both the cases they respond well to cephalosporins. They both will respond well to cephalosporins. Okay, Atul and Samantha. So now coming back, cellulitis and erysipelas, they both are bacterial infections of the skin. अभी देखते हैं इसको कैसे differentiate करेंगे. So the differentiation happens like this. Like cellulitis, let us write down erysipelas first. And cellulitis, the second one. So this erysipelas is caused by streptococcus, whereas cellulitis can be caused by streptococcus or staphylococcus, both. Okay, either streptococcus or staphylococcus. And another difference is erysipelas, the most common site is the face, whereas cellulitis, the most common site is the lower leg or the lower limb, right? That is the most common. And when you write about the borders in erysipelas is well defined, whereas here it is going to be ill-defined borders. Ill-defined borders can be seen. And finally, how do we find them together is, In both the cases, erysipelas and cellulitis, here you can note down patient presents with fever, chills, and a inflamed skin. Patient presents with a fever, chills, and inflamed skin. That is how patient will present with both. Now just see logically. हमने क्या लिखा है? Definition of cellulitis and erysipelas. Both are bacterial infection. In both, the patient is presenting to you with fever, chills, and inflamed skin. And where is this inflamed skin seen? If you can see inflamed skin in the face, then think about erysipelas. How will you identify? The borders will be well defined. Whereas if there is inflamed skin and it is present in the lower leg with the ill-defined border, फिर diagnosis हो गया cellulitis. That is how you can understand erysipelas and cellulitis. Clear? And in both these cases, they respond very well to penicillin group of antibiotics, isn't it? So they both respond well to penicillin antibiotics. That is the treatment of erysipelas and cellulitis. Bulla normally where to seen? See, bulla can be seen anywhere, right? Jaise if you have a burns injury or a scald injury, the patient may come to you with bulla. You can see bulla in pemphigus vulgaris, pemphigus foliaceus, in those kind of diseases as well. Okay. So now let's see one more question. And this question is, describe Tinea Capitis and classify its clinical types. Very important question, right? Because Tinea Capitis, it's something very important among all the types of dermatophytosis, right? So how do we start? And again, since we have been discussing about different cases, can anybody tell me if you get a question about Tinea Capitis, how should you start? First, you have to describe what is Tinea Capitis. So what is Tinea Capitis? Tinea Capitis is a dermatophytosis. Okay, or let us say is a type of dermatophytic fungal infection of the scalp. Okay, that is a definition of Tinea Capitis. Capitis because it is over the scalp. Tinea Capitis is a dermatophytic fungal infection of the scalp, more commonly seen in children, and caused by trichophyton or microspora. So this is how you can define a Tinea Capitis. Tinea Capitis is a fungal infection of the scalp, seen very commonly in children and can be caused by two species, that is trichophyton or microsporum, isn't it? So ये हो गया definition. I think definition we have already covered, right? Now the question was, what is a clinical classification, right? So in the classification, we can divide Tinea Capitis into two types. One is non-inflammatory type and the other one is inflammatory type. So one is non-inflammatory, the other one is inflammatory. And you have to remember what are the inflammatory and non-inflammatory types. Non-inflammatory types are gray patch and black dot. And inflammatory type is Irion and Favus. Inflammatory type is Irritant and Favus. So these are the types. Now just see the question. Describe Tinea Capitis. Description में हमने दिया already. And classify its clinical types. So in the clinical types, how many types are there? Non-inflammatory and inflammatory. Inside non-inflammatory, how many are there? Two types. Gray patch, black dot. And in inflammatory, Irritant and Favus. Now there is one more thing that you can do. When you get these kind of questions, it is okay to describe all these four in just one sentence. Just say, hey, why do we call this inflammatory? Irritant and Favus. We call it as inflammatory because they leads to scarring alopecia. There will be hair loss and there will be no growth of the hair again. इसीलिए they will lead to a scarring alopecia. And just write down one sentence each for every type. So let us write down one sentence each for every type. Like gray patch, what happens? It appears gray in color because hair breaks away from the scalp. So just imagine the hair is breaking away from the scalp. That is why we call it as a gray patch. Whereas what happens in a black dot? In black dot, hair breaks very close to the scalp. Like just imagine कि आपने trim किया है, isn't it? After trimming of the hair, you can see multiple black dots, right? वही है black dot. When the hair breaks close to the scalp, it is called as a black dot. It is called as a black dot. So gray patch is done, black dot is done. The next one is Irritant. So in Irritant, this happens when there is a painful swelling of the scalp along with alopecia, along with scarring alopecia. So when a patient will present to you with painful swelling, okay, a child is coming to you with a pain in the scalp, you see there is a big swelling and there is an alopecia, then think about Irritant. And Favus is endemic in Kashmir. It is endemic in Kashmir and also presents with scarring alopecia. And also presents with scarring alopecia. So what did we do here? We just mentioned one sentence each for each of the types of Tinea Capitis. Gray patch, black dot, Irritant, Favus, right? Gray patch में क्या होगा? Hair breaks away from the scalp. Black dot, hair breaks close to the scalp. Irritant, painful swelling होगा. And in Favus, it is more endemic in Kashmir, also presents with the scarring alopecia. So these are the various types of Tinea Capitis. Tinea Capitis. And finally, so I did not split it into various pages. So I'll just write down regarding the management also. How do you treat them? So regarding the treatment, you can do a wood slam examination where you can see a green fluorescence. So this is one of the tests that you can do in the cases of dermatological diseases, that is called as a wood slam examination. So in wood slam examination, you may get a green color fluorescence, especially if it is caused by microsporum. Especially when it is caused by microsporum. And the second one is you can always do a KOH test, because whenever there is a fungal infection, always do a KOH and the KOH will be positive. What is the full form of a KOH test? The full form of a KOH test is potassium hydroxide test. ये जो test है ना, it is an investigation of choice. Whenever there is any fungal infection, always do a potassium hydroxide test. That is the investigation of choice. Yeah. And finally, once you get this positive, you can treat the patient with griseopulvin, which is the drug of choice, or you can use one more agent which is called as terbinafine. Both these are antifungal agents which can be used in the treatment of Tinea Capitis. Which can be used in the treatment of Tinea Capitis. Clear? So Atul was asking ki when the hair breaks away from the scalp, why is it gray? See, when it is very close, it looks like black dot. When the hair breaks at different level, it apparently looks gray in color. Okay, that is a perception that we have. Easily we call it as a gray patch. It apparently looks gray in color when the hair breaks at different levels away from the scalp. Clear? That is about this question. Now let's see another question. Write a short note on herpes simplex virus skin infections. Anybody? Now it is already mentioned in the question itself. Herpes simplex is a virus, right? It is a virus. So now let's start with the core features of herpes simplex virus. So we will start with the treatment itself, of the definition itself, right? So please write down. Sumit is asking what is the treatment of comedones. See Sumit, comedones comes under acne vulgaris, है ना? तो comedonal acne का जो treatment है, it should be with retinoids, like topical retinoids, adapalene, retinoin, all these are examples. Okay, Sumit. So now let us write down, come back to the question, herpes simplex. Do anybody want to give your idea or your answer of definition in the chat box? Just give it a try at least. देखते हैं कि how much are you able to describe or define a herpes simplex virus infection. Anyone? Just give it a try. No problem if you get it wrong. So how I would like to define herpes simplex virus is herpes simplex virus infection is a viral infection, isn't it? It is a viral infection which presents with grouped vesicles on erythematous base, where the patient presents with a group of vesicles on an erythematous base with a tendency of recurrence. That is how we can define a herpes simplex virus infection. Okay, it is a viral infection. How does it present? It presents with a group of vesicles together, and they will be over a erythematous base, and there is a tendency to recur or recurrence, isn't it? And then you can write down that there are different types. One is HSV1 and the other one is HSV2. HSV1 and HSV2. And we can also remember that infection above the waistline is usually caused by HSV1 in 90% of the cases. Okay, whereas infection below the waistline is caused by HSV2 in 90% of the cases. In 90% of the cases. Easy है ना? HSV1 above waistline 1, below waistline 2. जैसे HSV around the lips 1, HSV in the genitalia 2. That is a simple point here, right? And coming below, there are different clinical types. Okay, there are different clinical types. For example, infection of the lips, we call it as herpes labialis. Infection of the genitalia, we call it as herpes genitalis. है ना? And infection of the palms and soles, we can call it as herpetic whitlow. Herpetic whitlow. I meant waistlines, Samantha. I just meant waistlines. Hip है ना, hip. Over the hip is above the waistline. Below the hip is below the waistline. That is it. I hope it is clear. So now coming down. So based on the site of the lesion, we name it differently. Herpes labialis, herpes genitalis, herpetic whitlow, etc. Okay? That is how we are going to name them. And then finally, diagnosis, Anna. So how do you make a diagnosis? Which test can we do to diagnose herpes simplex virus? We can go for a Zang smear. Can go for a Zang smear. And what you see in a Zang smear? In a Zang smear, you can see MNG cells. What is the meaning of MNG cells? Multinucleated giant cells. Or we can even go for a PCR testing, a PCR as well. And once you have the diagnosis, you can go for a treatment. And what is the treatment that is used for herpes simplex virus? It is antiviral agent, which is called as acyclovir. Acyclovir can be used in the management. So that is how you can answer a question regarding herpes simplex viral infection. Is that okay? Clear? Chalo. Let us do one more question. Right? Write a short note on herpes zoster. अब ये क्या है? What is herpes zoster? Yeah, very good. Samantha was answering. So anyone, can you please write down what would be your definition when it comes to herpes zoster? What all things can we write? First, short note, hai na? So let us give a short note on herpes zoster. Yeah, let us start here. Core features. Yes. So let us write down what is the definition first, right? So in the definition, what will you write? What is herpes zoster? Is it chicken pox? Nahi hai na? Okay. I can see that does not cross midline and all. But the definition में क्या लिखना चाहिए? Herpes zoster, isn't it? Is a viral infection. So just write down all the basics. Herpes zoster क्या होता है? It is not a bacterial infection, right? It is a viral infection due to the reactivation of varicella virus. Due to the reactivation of varicella virus. In where was this varicella virus present? In the dorsal root ganglion. In the dorsal root ganglion, right? And all these patients, there is going to be a history of chicken pox in the past, because herpes zoster is because of the reactivation of the chickenpox virus, isn't it? So that is about the definition of herpes zoster. And then let us write down the clinical features. How will the patient present to you with the chickenpox? Sorry, with the herpes zoster. Herpes zoster, which is also, you can also write down, also called as shingles. It is also called as shingles. So herpes zoster or shingles, how do they present to you? They present to you with a burning pain along with grouped vesicles on erythematous base on a dermatomal distribution. Okay, on a dermatomal distribution. So what will happen? Patient ko pehle chickenpox tha, right? So that may be in childhood. Now the patient is a 40-year-old, 50-year-old or a 60-year-old adult. Now there is a reactivation of which virus? Varicella virus in the body. So when the varicella virus becomes reactivated, they present to you with a burning pain along with vesicles on a erythematous base on a dermatomal distribution. Now, what is the significance of this dermatomal distribution? If the lesions are along a dermatomal distribution, the lesions do not cross midline. The lesions, they do not cross the midline. That is what Samantha had said some while ago in the chat box, right? So that is about herpes zoster presentation. Now, the moment you see this, you can reach out a diagnosis. Diagnosis is clinical diagnosis. So what do you mean by clinical diagnosis? No need of lab investigation. That is another point that you will write. Additional 1 mark. Because no need to do any lab test. You just see the patient, you know the diagnosis. Easily, this is a clinical diagnosis. Okay. And then when it comes to the treatment part, there are two things that you need to take care. One is that there should be a management of the burning pain. Second one, you have to take care of the vesicles. So in this case, you will use acyclovir as the antiviral agent. And for the burning pain, you can go for gabapentin for the burning pain. For the burning pain. But don't stop your answer here, because please write down whenever you get a question on herpes zoster, it is better you write down the most common complication of herpes zoster, because that is going to give you additional marks now. What is the most common complication of a herpes zoster? Anyone in the chat box? Most common complication is called as post-herpetic neuralgia. Post-herpetic neuralgia, which means there is a persistence of burning pain for several weeks. So this burning pain is going to persist for several weeks. That is why we will be using the drug gabapentin for post-herpetic neuralgia as well. For post-herpetic neuralgia is as well. हाँ तो ये काफी है, because we have got a question है ना about herpes zoster. So herpes zoster क्या है? We have already mentioned herpes zoster is because of the reactivation of the varicella virus, and it is also called as shingles. Then we also said what is the clinical features? Clinical features is like vesicles hoga, burning pain bhi hoga. Then we are talking about how is the diagnosis? Diagnosis is clinical, कोई lab test की जरूरत नहीं है. And then finally treatment. Treatment में we are telling the main treatment is acyclovir, but not only acyclovir. We have to start on gabapentin as well. And then we are also mentioning कि there is a complication. Complication क्या है? Post-herpetic neuralgia, which means there is a persistence of the pain for several weeks. So for that reason, we will continue the patient on gabapentin. So that is enough when it comes to a short answer question, and the treatment is with gabapentin, because we are going logically here, and that too Please see the entire discussion mein we have tried to go in the same format. Define, clinical feature, isn't it? Diagnosis, management. Diagnosis and the management. So yes, that is it about all the important topics. We have one more session that is coming up in dermatology. So if you have any feedbacks, if you have any problem in learning any specific topic, अगला जो फर्रे series में जो होगा in the next lecture, I'm planning to come up with some important topic like the sexually transmitted infections, है ना? And probably leprosy, or otherwise we'll try to club it with pemphigus group of diseases, pemphigus vulgaris, pemphigus foliaceus and all, right? Yeah, psoriasis and acne vulgaris, we have already done this last year in the Farre. It is available in YouTube in the same PW MedEd YouTube channel. That is the reason why I did not repeat the same topic. Okay? So just go through the same video once where I have discussed about acne vulgaris, vitiligo, psoriasis, and all those things. Yeah, it's a very good suggestion. We'll add more pictures next time in the next lecture so that it becomes much more easier for you to understand. Is there any other topic you would like me to do next time? Can just let me know. Or if there is any topic that you feel very difficult to understand, I'll be happy to add those topic as well in the next lecture series. So if not, then that is it for the day. Okay. And just keep checking on MedEd app and this channel for more such videos. Okay. Thank you so much for being a very interactive crowd, especially. I'll see you again in few days time with the second lecture. Thank you so much. Atul says lichen planus. Definitely I shall add lichen planus also to the next. Thank you.